Gary gets his glasses on.
Yeah.
So, for those of you that haven't been involved previously, the approach of this presentation is really twofold. It's primarily to tell you where to find things in the RFPs. Since this is a modular project and it's new to pretty much the United States, we took a look at how we should put our modules together. First module being the SI for system integration. You got to have the infrastructure, the architecture before you can start laying stuff on top of it. My background is on the business side, not the technical side. I always defer to folks for the technical stuff. What I hope to bring to any project is to be able to translate between the state business need and the technical vision about what that looks like. Let's see. So second is data services, which is business intelligence, reporting, data warehouse. Then yesterday we talked about sort of shifting gears, moving more from the technical side to the business side. Our first business RFP was QA, which included TPL, fraud abuse detection, program integrity, quality reporting, auditing. It's really more about making sure that the state is not only doing the right thing, but being able to prove that you're doing the right thing. Which then brings us to, I think we did this one, right? Yeah. Really? Coordination? I thought we did. Okay, so.
I don't recall you spelling out those acronyms. 20 of them.
OIG, Office of the Inspector General. OIG, Office of the Attorney General. Mafuku.
Medicaid fraud.
Medicaid fraud. Yeah, it was on the previous slide. So this is the.
It's a new day.
Huh?
It's a new day.
Okay, so these are the CSS, critical success factors from CMS's checklist. The approach that the state has taken to certification is to certify based upon MMIS business as opposed to the MIDA business processes. The requirements are all the same, it's just a matter of how you lump it together. Since the state's RFPs more closely match the business, the state made the decision to use the business checklist, and in the checklist are the CSS.
Gary,
okay?
Are you sharing slides? We don't see slides out here.
That's okay. It's the same one we talked about yesterday.
Let me do that right, as she said. So she said. Yeah, let me open that up, and then you can bask in the glory of the slide.
Yay!
You haven't been recording?
I am recording.
Okay.
Now they have it.
So.
And you're on record.
Bing. Bing. Turn the slide.
Oh, are we at Bing time?
We're at Bing.
Okay.
Not to be confused with Google search. We're at Bing search. Come on.
Here we go.
Okay, so I previously mentioned this, I think the first day, maybe the second day. All of the modules have all of this stuff about project management. Each vendor, each contractor is responsible for their own reporting, their own risk assessment, their own issues, continuous process improvement, all of that stuff. So everybody basically gets this. The SI, lucky team that they are, they also get to make sure that everybody is playing nicely and all of those things are coming together. The state and the SI collaboratively working to make sure that all of the full project management needs are met. Okay? Cool. Bing. New and exciting features of QA. We did not actually get to this. So every state does some program integrity, but with the addition of all of the data being in one location through data services, with the addition of the tools that we're asking a QA vendor to bring, we should be able to do better, more proactive program integrity. We also are looking forward to TPL. TPL is twofold. I sort of mentioned this yesterday. There is the recovery aspect, which is if I've already paid the claim and after the fact I find out about it, give me my money back. And then the other is cost avoidance. Cost avoidance being the idea that I already know you have insurance, so when that claim comes in, if you don't have what your other carrier paid, then I'm going to deny it outright. If it does, so let's say the Medicaid is going to pay $50, your Blue Cross paid $30, the most that Medicaid is going to pay is then $20. Okay? Fraud abuse detection applies to not only providers, but we're also going to start looking at members, doctor shopping, For providers, it's upcoding, it is unbundling, the traditional stuff, but we've also asked the QA vendor to come with lots of brilliant ideas, much like we ask SI, DS, QA, we will ask BMS, and we are asking FS. Bring us your knowledge. Help us to be better. So in terms of fraud and abuse, we expect them to bring some knowledge about that as well. Coordination of quality recovery activities. So we sort of have talked about coordination of auditing, but we're also looking for coordination of recovery, right? If I am recovering on a claim for TPL, we need TPL to let claims know, and we need claims to put some flag on it so that someone else isn't trying to recover at the same time. As much fun as it may be to pay $50 and get $75 back, we can't really get away with doing that. So we have to have that coordination across the recoveries. And automated processes. This state, well, actually, every state I've ever been in has, I like to say Medicaid folks are the most brilliant in terms of taking old archaic systems and making them work for them. The problem with that is a lot of it is manual processes. The problem with that is sometimes you use this field for this period of time to mean this thing. Then 6 months later, now this field means something else, and a year later it means something else. So all of that data conversion, I see people already grinning. They know this, right? This is not news. But all of that is stuff we're looking to improve upon going forward. Back to Dwayne and his master data mapping. I know that he's been doing a lot of work on this thing that's called this. Is it the same across all of these different divisions? So we'll get to that, but automated processes are expected in every RFP. Bing! Okay, that brings us to benefit management services. Now this grouping is more about the actual services that someone gets. It's not like QA, I'm checking to make sure they were right. I do want to make sure they're right as part of benefit management services, but this is more the doing, not the checking after the fact. Member management. A key thing in member management is SDT. I got a candy bar for anybody that knows what it stands for. Okay, it's my candy bar then. Here, Mark? Early?
Prevention.
Nope. Bing. Wrong answer.
Oh, early and periodic.
Periodic?
Did you say big?
I said big. Early periodic screening, diagnosis, and treatment. It used to be diagnostic testing. Now it's diagnosis and treatment. This basically is immunizations. It's well baby stuff. Some states like Washington brought in women's preventative, PAPs, mammograms. It's early periodic screening, diagnosis, and then treatment. You've got something, we want to do something about it. So it makes it a little more involved to actually do the follow-up on that. There's some other stuff around member management that we'll need to bring in. That will be defined as through the design sessions. Most of member eligibility is done in Aspen, but there will be stuff about members that we need to know that doesn't necessarily come from Aspen. Assistance with, oh, this is a good one. Assistance with the system and data support, blah, blah, blah. Care case management. So the state has multiple different divisions, administration bureaus, that do case management type functionality. DOH has some, the waiver programs, the 1115 waivers, the MCOs do some, the 1915 waiver, there's a community benefits program. So there's a lot of these little things that you have to be eligible for. You have to have a financial eligible, you have to have functional need, and then there needs to be a roster, and this is primarily done manually in the state. So there's discussions going on right now about where does this actually live. So for the purpose of the VMS RFP, we put it in for it to go to CMS. At the very least, we're going to need some sort of tool. But where full-blown case management, care management lives is yet to be determined. There's meetings going on between aging, DOH, HSD, to try and get to what does make sense around that. UMUR, utilization management, utilization review. So some folks, when they think utilization review, they instantly go to reviewing after the fact. This is really the proactive. This is the authorizations, prior auth, individual support plan, service and support plan, those are for the waiver programs. Level of care is how much care you need, plan of care is the plan, the prior auth, so that all falls under UMUR. Provider enrollment and management. So in order to pay somebody, you got to get them enrolled into the system. Provider enrollment and management, one of the key things that we're looking for here is not only credentialing at the time that you apply, but ongoing credentialing. Electronic health records, some folks, when you say electronic health records, they go to, oh, I got my record online. This electronic health record is specifically a program for incentive payments. It's short-lived. I think it expires in 2019. I have that in another slide. But that basically is providers that are performing services that have the right amount of MCO mix, that have the right amount of electronic record system that is certified. They get some money. So provider and management and electronic health records sort of go hand in hand. Pharmacy benefit management, PBM. This is all things about drugs.
Really?
Oh, yes. So if you want to know who your drug dealers are, they're at the PBM, right? This includes the authorization of it, the paying for it at the point of sale, the drug rebate. If you're new to Medicaid, you may not have heard of this concept of drug rebate. And basically, there's an agreement between CMS and manufacturers and labelers, I want to say from 74 on, I don't remember exactly. But basically, there is a rate that the state is liable for. But in the process of the payment, at the POS, when I get my drug, I pay whatever the charge is. Medicaid pays whatever the charge is. Then quarterly, there's a rebate amount that is collected back from the manufacturers and labelers. This is big money. There's lots and lots of money recovered here. This and TPL are your two main recoveries. So drug rebate is really important, and we expect the PBM to be able to complete that functionality. Benefit plan management. This is all about what services do I get? How do I put together a package of services that says, Sherry is, what year is this? She's 57, so she gets some women's wellness benefits. She qualifies for categorically needy, so she gets these set of benefits. This is all about putting the plans together to make sure that our clients get the services that they're supposed to be getting. Bing!
Hey, Sherry.
Yes, Paul.
I know you're going really fast.
We're trying to get through like 60 slides in 5 days.
Can I ask a few questions on that?
Absolutely.
That might be helpful for everybody.
This one we get through quick because it's just a picture. Go ahead, question?
This slide really scares me. This is a really long slide, lots of
Detail.
functionality.
Yes.
So as I look at that, a lot of those I recognize as mature COTS products that the vendor will probably bring to us.
Likely, yes.
So I'm picturing probably lots of different COTS products and several.
Likely, yes.
Is that likely? Okay, that's my first question.
We definitely think, well, PBM is going to be pretty much by itself. It doesn't align necessarily with the rest of them, right? PBM is like a full claims paying system by itself. So it should be a sub all by themselves.
Could you point out for us what you think are likely COTS products and how many of them there are on that screen?
Oh, sure. My best guess?
Yeah, just your best guess.
So I do know that out in the market, there's some people doing some work around member management. So I could see that as maybe not a COTS product, but an already developed product. So to me, there's a difference between COTS, right? That's like Excel, but something that's already fully functioning and working somewhere. So I could see member management not necessarily as a COTS product, but I would expect that functionality to already exist and that a bidder would bring that functionality. Does that help?
Sure. So that's one, the care management tool.
Yeah, so care case management is probably its own thing. UMUR, there's a couple companies, Qualys, does authorizations, shoot, what's the other one?
It's okay, I just want to.
There's a couple, yes. And so.
What about the ISP, SSP?
This would be, to me, this is all probably one COTS product.
Part
So-
of the UM?
Yes, so Qualys should have functionality that allows them to configure the rules around what are the authorization rules for SSP based upon the program, as opposed to a medical authorization based upon the program. Does that help?
Sure.
Okay.
Absolutely.
Okay. Provider enrollment and management, again, not necessarily a COTS product. There are a couple out there, Digital Harbor and LexisNexis, that do the credentialing. So I could see a vendor using those COTS products in order to meet the provider management. So parts of it.
So this is one that I think is going to be interesting to us, because a lot of the MMIS vendors have provider enrollment management embedded in there.
Yes,
What we're thinking was more part of the.
as part of the core system, yes.
So this might be a bit of a teaser to get them to break it out of MMIS and say, we can propose it to you separately as
Yes.
part of your VMS, and by the way, we'll be back, because we're going to bid on.
Because we want to bid your claims too, because then we can already go, look, we already have those links, right?
Okay,
So provider taxonomy, all the credentialing, all of the indicators from provider management will be used, or most of them will be used by claims. So oftentimes in a full solution, those things go hand in hand. As Paul said, we are talking about breaking stuff up. So provider management, provider enrollment would need to be able to be disconnected from whoever you are. Let's say you're HP Enterprises. HP Enterprises say, we have all these modules. CNSI says, we have all these modules. Everybody says, we have all these modules. If you look at all those modules and you've been around a while, they basically are subsystems, right? It's the way that everything has been put together in terms of being able to function in the past, but it hasn't necessarily been broken apart. And we are asking people to break things apart.
Right. So thank you for talking through that. And the reason I wanted us to do it is just to illustrate that with these upcoming BPO procurements that we're doing, Prime is probably going to bring to us several COTS products from several different companies.
That all have to be integrated and managed.
And so the integration challenge becomes pretty enormous, which all of us are going to be really involved in how we're going to integrate that many products.
Yes, so there's that within the module, and then we now have to integrate with the other modules.
That's right.
So it becomes increasingly more complex than like hiring somebody to do the whole system, that the whole system already exists.
Right, I don't think it's near as prevalent in our DS module, but in the other modules that are coming, the integration of all of these components is going to be, I think, our biggest challenge.
Ding, 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 ding.
So I just wanted, you know,
Don't.
while we're all here focusing on setting up our integration platform, this is the challenge that's coming to us over the next few years. Many products from many companies. If it was 5, wouldn't that be beautiful and simple? It's not going to be 5 like our 5 modules. It's going to be 25, it's going to be 35, it's going to be something like that.
Yep.
So thanks for letting me.
And I don't know how many of y'all have been around for a long time, but there will be a lot of this. For those on the phone, it's finger pointing, right? This is where we're expecting our SI to go, no, that really is your responsibility. And if you can't get it across to them, that's when the state gets to step in with the hammer. But even within a system, right? When I worked for CNSI, we had claims, we had provider, we had member, blah, blah, blah. There even was within that one company finger pointing about who that belonged to. Now you're going to have across companies, across subs, across vendors. So it will be very exciting to manage. There's a tsunami of work headed our way. All right. So again, I did kind of a cute little visual. PBM, really, they are pretty much a claims-paying system by themselves. And then benefit management. No, this is not signing the contract. This is not even looking at the contract.
There's 3 more to go. Well, 4, actually.
Move on. We got
Speed.
chop, 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 chop.
Where are they?
Okay, so member management. Here's the CSS, critical success factors from member management. And sort of kind of like I've been talking before, we really are looking for better experiences for people, better experiences for the clients. We don't want someone to be on Medicaid for 10 years and not have gotten good quality care. We don't want the state to be paying for, excuse me, but crap, right? It's all about making sure people get the right benefits, the right care, the right time, so that they can do better, be better. And so information, right? We've already talked about a single data warehouse that has tons of information about me. If you looked at a data warehouse about my history, you'd go, okay, she worked here for a while, she worked there for a while, she worked there for a while. Really, she drove cabs? Wow, that's interesting. That isn't necessarily something a doctor or a state worker would know when they go and look at just the MMIS claims. But if you know that they have behavioral health services, if you know that it's a kid and they are at Head Start, so you know they're getting nutrition, there's a lot of information we can know about people to improve outcomes, which then also leads to better claims payment. Provides information to support member eligibility. So I already talked about Aspen is the primary source of eligibility, but as the state grows and CMS offers optional programs, waiver programs, et cetera, maybe some of that eligibility for a waiver program would be done by somebody else. Right now, work is done here, given to Aspen, and then Aspen decides the final eligibility. But that sort of stuff can be done if we have a single source of data and be able to share that. Medicare buy-in. So Medicare buy-in is basically, I now have been on this project for 12 years, and so now I'm eligible for Social Security. I can have Medicare. Part A, because I'm a citizen with all the rules apply, I get for free. Hospital, I get for free. Part B, lab, physician, physical therapy, blah, 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 that stuff I have to pay a premium for. So buy-in is the concept that it is cheaper for Medicaid to pay your Part B premium to have you have Medicare to cost avoid, to cross over those claims. And so Aspen does that part here. They do the sending off of the files. They get the accretions back. Yes, there's a whole lot of work around matching to make sure it's the right person because people use different names. Date of birth might be off, whatever. So, but once that happens, then that information needs to go to the rest of the system to know that I have Medicare so that I can cost avoid and do those crossover claims. So that's member management CSS in 3 minutes or less. Boom. Assistance with, okay, so again, back to the care case management. So we've sort of talked about this. A lot of this work is actually done in New Mexico by the MCOs. But the state still has a responsibility for making sure the MCOs are doing that in order to meet the CSS. So it's one of the other things that we have talked about in VMS is that your tool that you provide to us should allow us to create case types. One of those case types could be MCO contract management, so that I have some fields that say this is who the contract's with, this is what their turnaround time for claims processing is, this is their PMPM per member per month or capitation. This is all the stuff about this contract. Right now, CCCB, Centennial Care Contracts Bureau, they do a lot of that work manually. They get reports from the MCO, and then they match it against stuff that they have in the data warehouse. One of the things we're looking forward to, yay, is that we will get more information from the MCOs to put into the data warehouse here so that the state workers don't have to look at a report from the MCO to compare it, that we can automate that, we can make all those things happen. 1915 waiver, I already started to talk about that, home and community-based services. This basically is, it can be, should be, cheaper to keep me in my home than put me in a facility. I'm getting a little old, I'm getting a little Alzheimer-ish, so maybe I can't fix my own meals anymore because I forget to turn the stove off. I can have a personal care attendant come in, cook for me, make sure that I eat healthy, make sure that my breakfast is not M&Ms. And so we are looking for that care case management tool, even if we don't do full-blown care management in the MMIS, but I could set up a tool that says, this is this type of thing for monitoring purposes. Okay? PIHP, the prepaid health and inpatient health plan, prepaid something health plan, I forget. But basically it's about hospital plan. It's just another type of coverage. Right now, New Mexico does not do PIHPs or PAHPs. Bing!
No big. Let's stop here and let me open up the phone.
Questions?
That's what I'm going to. So, hey, so we're going to end here for the day, but we want to open up for a few questions. We've got a couple of minutes, but let me start on the phone and see if there's any folks on the phone who've got things they want to ask Sherry based on the presentation today.
Come on, don't be shy. Okay, Mark, I'll give you a candy bar just for trying. Stop by my desk.
Thank you.
So any folks in the room? Questions for Sherry? Okay, we then will.
Did I say anything that scares you?
Everything you said scares me.
That whole
It should.
slide makes me a little nervous.
Yeah, everything would be friends.
It should.
We're bitter.
Did I say anything that is old news to you? Hopefully some of y'all have already heard this concept of modules. Did I tell you anything that was new today? Okay, good.
Hey,
Heather?
this is Marie. I did have a question
Sure.
for Sherry. It was back on the slide with where you talked about benefits management plan
Sure.
for the individual, when you were talking about the individuals.
Uh-huh.
So my question was, is it New Mexico's concept to have this benefit management plan based on the individual's issues, or is it planning for a benefit plan based on a set of criteria and circumstances, or does
Okay.
everybody get their own individual plan?
So basically the question is, how do benefit plans work? And I'll try and do it as quick as possible. So a benefit plan is typically tied to a category of aid. Categorically needy gets a set of services. Then I, as a member, would have that category of aid on my member record so that when I go into the doctor, the hospital, whatever, and they bill for a service that's within that grouping, it gets paid for. If they try and bill or pre-authorize for something outside of that grouping, it does not get paid for. So each individual has a benefit plan, but the benefit plans are not per individual.
But we do offer an adult benefit plan specific to that the MCOs can provide. So if somebody has a specific category, for example, a Nigerite adult, it's possible that they can work with their MCO and based off of those circumstances get an extended adult benefit plan.
That is a good point. The MCOs also may give benefits beyond what Medicaid gives. So what the MCO does can be a little bit different. At the bare minimum, the MCOs must cover what Medicaid would have, but they can cover above and beyond. Good point, Carmela. Thank you. Anybody else? Okay.
Okay, great. Sherry, thank
Remember
you
to tip
again.
the wait staff.
That would be the bing guy.
I'll be around all week.
No, you're the entertainment. I'm the wait staff of the bing.
Bing.
All right.
All right, thank you, everybody.